All right, welcome everyone. If you're managing patients after bariatric surgery, you already know that the surgery itself is just the beginning. Today, we're going to walk through a really practical guide to their nutritional management, hitting all the high-yield stuff you absolutely need to have on your radar.
So let's kick things off with a clinical hook. Picture this. Your post-op patient comes in with persistent vomiting. It's easy to write that off as just a GI issue, right? But it could be a massive warning sign for a truly devastating neurological emergency. Hang on to that question, because the answer really drives home how high the stakes are here.
But before we get to the answer, let's back up and talk about our core mission as clinicians. Because really, it's all about a delicate balancing act. Here it is, the main takeaway. Success is not just about the number on the scale. Not at all. Real success is hitting that weight loss goal while protecting the patient from nutrient deficiencies and making sure they hold on to their muscle. We're not just trying to make them smaller, we're trying to fundamentally change their metabolic health for the better.
So to pull off that balancing act, one of your very first jobs is to guide that patient through their diet progression. And this isn't random. It's a very structured journey that you've got to manage carefully.
The whole thing is broken down into 4 really distinct stages, and it's all designed to let that new stomach pouch heal properly. You start with clear liquids, then you move to things like protein shakes and pureed foods, then you graduate to soft solids, and finally, you bring back regular textured foods. It's a slow and steady process for a reason.
And here's what that looks like on a timeline. The first couple of weeks, it's all about liquids. Hydration is king. Then, from about week 2 to 4, we start bringing in those soft solids. And usually, by week 6 to 8, most patients are getting ready to transition back to a more normal diet. But, and this is a big but, it always comes down to how the individual patient is tolerating things. Now, these simple rules, they can literally make or break a patient's recovery, so you have to drill these points home. I'm talking eat slowly, chew everything until it's basically mush, stop eating at the very first hint of being full, and this one is critical, do not drink with your meals. You have to separate liquids and solids to avoid overwhelming that tiny new stomach while still making sure they're getting enough fluid throughout the day.
Okay, so once you're past that initial diet phase, your focus shifts to the long game. And out here, in the long term, the challenges you'll face can be very, very specific to the type of surgery the patient had.
Let's compare the 2 big ones, the Roux-en-Y gastric bypass or RYGB and the sleeve gastrectomy. With a gastric bypass, you got to be on high alert for something called dumping syndrome, and you should be checking for B12 and iron deficiencies way more often. With a sleeve, on the other hand, acid reflux is the much bigger complaint. Knowing these differences helps you anticipate what your patient might be struggling with before they even tell you.
So what is dumping syndrome? Because your bypass patients will definitely ask about it. Basically, food, especially sugary stuff, gets dumped from the stomach into the small intestine way too fast, and that triggers this intense, full-body reaction. It feels awful, for sure. But, it also works as a pretty powerful negative feedback tool, teaching patients which foods to stay away from. All right, let's talk about what I think is the most critical part of long-term management, micronutrient deficiencies. These things can sneak up on you. They're subtle at first, but if you miss them, the consequences can be just devastating.
Just look at that number. Let it sink in. 1 in every 3 of your gastric bypass patients. This isn't some rare textbook complication. This is something you should almost expect to see. It's exactly why lifelong lab screening is completely non-negotiable.
Think of this table as your clinical cheat sheet for the Big 4. Iron deficiency is super common, especially after bypass. B12 deficiency can lead to that megaloblastic anemia and even permanent nerve damage. And then there's thiamine. Notice how it's a risk in any bariatric procedure if there's prolonged vomiting? Well, that brings us full circle, right back to our opening question.
So here we are, that patient with the nonstop vomiting who is now confused and can't walk straight. Your alarm bells should be screaming Wernicke encephalopathy. It's a neurological emergency from a severe lack of thiamine. So do you remember the classic triad? Here it is, confusion, weird eye movements like nystagmus, and an unsteady wobbly gait. And here's the key, you do not need all 3 to make the diagnosis. If you even suspect it, you have to act immediately.
Okay, everybody, lean in, because this right here is a never event. This is one of the most important things you will learn. Never, ever give a patient IV fluids with glucose before you've given them thiamine. That sugar will literally burn through the last tiny bit of thiamine they have, and it can push them over the edge into irreversible brain damage. The rule is simple. Thiamine first, always.
So here's your action plan. You suspect it, you immediately give high-dose IV thiamine. Don't even think about waiting for labs. At the same time, you're giving other key electrolytes like magnesium, and then of course you have to figure out and fix whatever was causing the vomiting in the first place.
And all of this brings us to our final point, your role. Your job is to be the long-term partner in this patient's health journey. Because remember, the surgery, that's just day one.
These are the 4 pillars that hold up successful long-term care. Every patient, 100% of them, needs vitamins for life. They need regular labs. You need to keep a close eye on their bone health by checking things like their calcium and vitamin D. And they need ongoing access to dietary support. This is chronic care for a chronic condition.
And here's a glimpse of what lifelong supplementation actually means. Just look at those doses. They're huge, especially for calcium and vitamin D. And this is a super important point. A standard multivitamin from the grocery store is not going to cut it. It's not even close. These patients need special, high-potency vitamins made for their new anatomy.
So, let's leave it with this thought. The operation itself, it's an amazing tool that reshapes a patient's anatomy. But it's your guidance, your attention to detail, your constant monitoring, that's what truly reshapes their entire life. Your role in this is absolutely indispensable.